Thank you very much, Ernst. Let's see. So contrast-associated acute kidney injury, and in this presentation, I'm going to use interchangeably contrast-associated acute kidney injury, CIN, contrast-induced nephropathy, and post-CT acute kidney injury interchangeably. So essentially, I mean the same thing when I use any of those terms. And the definition is an acute deterioration of renal function after intravascular administration of contrast medium in the absence of another likely cause. And this has been variably defined as a relative increase in serum creatinine of 25% or 50% over baseline, or an absolute increase in serum creatinine of 0.5 or 1.0 milligrams per deciliter over baseline. But the most sensitive definition is a 25% increase in serum creatinine over baseline, and that's what has been used in more recent studies, in most studies. Now, it's the pathophysiologic mechanism of contrast-induced nephropathy is unclear. It has been suggested that, and some studies have seemed to show that it's related to renal vasoconstriction, which then leads to renal medullary ischemia. Some studies show direct toxicity to tubular epithelial cells, and others suggest that an increase in oxygen-free radicals and/or in antioxidant enzyme activity may be responsible. And in any given patient, one or more of these mechanisms may be involved. Now, the natural history of CIN is a transient, non-oliguric decrease in renal function with an increase in serum creatinine that can be identified within 24 to 48 hours. It usually peaks in 3 to 5 days, and then in most cases returns to baseline within 2 weeks. But in a minority of patients, it does not return to baseline, and in fact, some patients need to go on to dialysis. Now, the risk factors for contrast-associated AKI are the following. The most important one is pre-existing renal insufficiency. But other important factors include diabetes, dehydration, advanced age, hypertension, multiple myeloma, hyperuricemia, and concurrent nephrotoxic drugs. Now, cancer patients in particular have an increased risk of contrast-associated AKI, and that's because many of them are of advanced age. Many of them are on potentially nephrotoxic anticancer drugs. Cancer patients often have metabolic disturbances related either to their disease or to their treatment. They can be septic due to immunosuppression. Stem cell transplantation can have a negative effect on the kidneys. And they're often dehydrated due to emesis, diarrhea, or poor oral intake. So many reasons why cancer patients are at increased risk for developing contrast-induced nephropathy. Now, with regard to potentially nephrotoxic anticancer drugs, these include not only chemotherapeutic agents, some of which I've shown here, and as you can see, these are some of the most commonly used cancer agents. In addition, targeted agents can be nephrotoxic. Anti-VEGF drugs, tyrosine kinase and multikinase inhibitors, BRAF inhibitors, and ALK inhibitors can have a negative effect on the kidneys. And also immunotherapeutic agents, such as interferons, CTLA-4 inhibitors, PD-1 inhibitors, and chimeric antigen receptor T cells. So there are many drugs being used on our cancer patients that can affect their renal function. And not surprisingly, the incidence of renal insufficiency is also increased in cancer patients. the risk or the incidence of chronic kidney disease is increased in this patient population. And this particular study showed that there is, let's go back. I'm not sure where the pointer is on this. Maybe it's this, there it is. Showed that 20% of the cancer patients in this study had chronic kidney disease that is of at least moderate grade with a GFR less than 60. But interestingly, 1 in 6 of these patients with chronic kidney disease had a normal serum creatinine. And that was corroborated in another study from the Cleveland Clinic, which showed that, that in a group of patients who came for contrast-enhanced CT, they evaluated serum creatinine and estimated GFR, and what they found was that 2/3 of the patients who had an estimated GFR of less than 60 had a normal serum creatinine based on their lab's normal, which is a little bit higher than most, but nevertheless, I think it again shows that serum creatinine is not a very good marker of renal function. And we know that, of course, because serum creatinine is influenced greatly by gender, muscle mass, nutritional status, and age. And in fact, GFR can be reduced by nearly half before we begin to see an increase in serum creatinine. And that's shown very nicely in this graph. On the top, we see the decline in renal function as it relates to a linear decrease in glomerular filtration rate. But notice that once we get to a GFR of 60, it's not until that point, when we've lost about half of our renal function, that we begin to see the serum creatinine become elevated, and that goes up markedly as GFR decreases. Now, the U.S. National Kidney Foundation has categorized chronic kidney disease into 5 stages, and the patients who are at the greatest risk for contrast-induced nephropathy are those with at least stage 3 or greater chronic kidney disease, that is, with a GFR of less than 60. Now, I'd like to just look historically at our concept of contrast-induced nephropathy. The early studies looking at this showed rates as high as 30%, which is alarming. 1/3 of patients undergoing contrast studies developing CIN. Well, the reason for that is that all of these early studies were done on patients who received contrast intra-arterially. These are essentially patients who are undergoing cardiac catheterization. And there are huge differences between intra-arterial and intravenous administration of iodinated contrast. For one thing, patients who undergo cardiac catheterization are more likely to have comorbidities such as diabetes and hypertension, which in themselves are independent risk factors for AKI. The volumes of contrast that are used for cardiac catheterization tend to be substantially higher than those used for CT. And probably one of the most important reasons is that the very act of catheterizing the arteries is detrimental because it causes cholesterol emboli that can shower the kidneys and cause acute changes in renal function. So it's really important, if we're going to evaluate what the risk of administering contrast is to patients in general or to cancer patients, we need to look specifically at intravenous injection, because that's what we're doing when we send our patients for contrast-enhanced CT. And I've listed here 3 of what I consider to be some of the best controlled studies looking at this. These are 3 studies that looked at And these were prospective, randomized, controlled studies that compared standard low-osmolar contrast medium with iso-osmolar contrast medium, all in patients who had chronic kidney disease. So all of these patients had to have an estimated GFR of less than 60 to be included in this study. And what we see, the two things that are important here, number one is that even in, and I should point out also that in this study, patients had to not only have stage 3 chronic kidney disease, but they also had to have diabetes. And in all of these studies, the incidence of CIN was only about 5%. The second take-home point here is that there was that the iso-osmolar contrast agent, also known as iodixonol or Visipeg, did not have any protective effect over standard low-osmolar contrast medium with regard to the development of CIN. Now, in this study, again, we see that the incidence of CIN is about 5% in this group of patients who have stage 3 chronic kidney disease, but it strengthens as GFR goes down. So in patients who have estimated GFR less than 45, there's about a 10% incidence of CIN. Now, interestingly also, this study looked at a control group of patients who did not undergo contrast-enhanced imaging. They looked at individuals who underwent non-contrast CT and found that the overall incidence of acute kidney injury in this group was the same as in the group who received intravenous contrast. So raising the question of, number one, whether contrast-induced nephropathy actually exists or what its role is, how it relates to all of this. And very astutely, about 10 years ago, Jeff Newhouse really raised this issue about the fact that if you look at all of the studies looking at CIN, very few of them, a very, very small number, looked at control groups. That is, compared the patients who received intravenous contrast to a similar group of patients who did not receive intravenous contrast. And in this study, they looked at that time, back in 2010, the 5 studies that had used control groups, and they found that the incidence was about 5% in both groups, in patients who received intravenous contrast and patients who underwent non-contrast enhanced CT. A few years later, there was a meta-analysis that included some additional studies. At this point, 13 studies had used control groups, and what they found in this meta-analysis was that in these studies with control groups, there was a similar incidence of AKI, dialysis, and death when you compared the individuals who received contrast media and those who did not. So what does this all mean? Well, I think that what we can glean from these studies is that in any group of ill patients, some of them will develop acute decline in renal function from something. And it doesn't have to be the administration of intravenous contrast. It may be a coincident event, such as an adverse reaction to medication or some other nephrotoxic insult, such as dehydration or hypovolemia. And other studies, which I'm not showing here, have shown that there are physiologic daily variations in serum creatinine and GFR. So how do we make sense of all of this? Well, there's one additional thing that we haven't yet taken into consideration that needs to be taken into consideration, and that is the possibility of selection bias, which is to say that it's entirely likely that patients who are selected to undergo unenhanced CT might have more severe illnesses, additional comorbidities, or exposure to nephrotoxic drugs as compared with patients who are selected to undergo contrast-enhanced CT. And so a way of getting around this is to use what's called matched cohort propensity score analysis. And this is simply a statistical method by which selection bias can be minimized or reduced in a retrospective study by matching patients based on risk factors. And I'm going to show you the conclusions from two excellent studies that were done recently at the University of Michigan by Matt Davenport and his colleagues. And what they found in these two studies were that low-osmolality contrast medium that is administered intravenously for CT is, in fact, an independent risk factor for post-CA-AKI. But it does not occur in patients with stable serum creatinine less than 1.5 or a stable eGFR that is 45 or greater. In addition, they found by doing this propensity score matching that there are many other factors that contribute to the development of post-CT-AKI, and not all of the cases of post-CT-AKI are in fact due to the administration of intravenous contrast. They're due to some of these other factors. And these other factors likely account for the equivalence in post-CT-AKI rates after unenhanced and contrast-enhanced CT that were shown in some of these recent studies that I just showed you. So what should we do? So I think the bottom line is, I think some of these more recent studies have put things into perspective. Number one, the risk, even in patients who are at risk for AKI related to contrast administration, is relatively low, only about 5%. But it is an independent factor, and we need to be aware of that. So what should we do? Well, the first thing we should do is we should identify the patients who are at risk for CIN. And those include patients who have a stable serum creatinine that is greater than 1.5 or a stable eGFR that's less than 45. The next thing we can do, once we've identified this group of patients who are at risk, is determine whether it's necessary to do a test that involves the intravenous injection of iodinated contrast material. Is there an alternative study that would allow us to get the same information so that we wouldn't have to put these patients at risk? If not, then the best thing we can do is hydrate these patients. And many studies have shown that various methods of hydration, preferably starting 24 hours before the CT examination, can be very helpful in mitigating the effects of intravenous contrast in this group of high-risk patients. Another thing we can do is minimize contrast dose. But we have to be careful, because the worst thing we can do is minimize contrast dose and get a study that's non-diagnostic in one of these patients at risk. We don't want to do that. So if we can minimize contrast dose, we should try to do it, but we want to make sure that we get a diagnostic study. And finally, we should stop nephrotoxic drugs that the patients might be on, preferably 24 hours prior to contrast medium administration if possible. And I thank you for your attention.